Okay, so I'm really excited tonight or this afternoon to introduce Professor Sarah Hawkes. Sarah Hawkes is a medical doctor with a degree in sociology and a PhD in epidemiology and public health. She's professor of global public health at University College London, where she leads a research theme analyzing the use of research evidence in policy processes, particularly in relation to gender and health equity. Sarah's co-chair of the Lancet Commission on Gender and Global Health, and co-director and co-founder of Global Health 50/50, which advances action and accountability for gender equality in global health. She's lived and worked for much of the past 25 years in Asia, where she has gathered evidence, collaborated to strengthen capacity, and operated at the interface of policy and research communities, working alongside national governments, UN agencies, and civil society organizations promoting gender equality, health equity, and human rights in health policies and programs. So with that introduction, I'm very happy to welcome Professor Sarah Hawkes. Sarah, over to you.
Thank you, Ben.
And you don't...
Yes, I just before starting, I realized you can't quite see my slides. But whilst
I'm
the
getting
technical
that
side is getting sorted out, first of all, many thanks for inviting me here. It's just fantastic, as I'm sure you all feel the same way too, because I imagine some of you have come straight from undergrad, perhaps. And let's face it, you've had the most appalling public health experience that any of us can imagine. You haven't sat in lectures for full time for 3 years. You've had a really disrupted and challenging 3-4 years of student life before now. So welcome to being in a room full of people. Even if as a professor of global public health, I do have to remind you that numbers are creeping up again. So I'd encourage you all to get the next vaccine that's due to you. But I just do want to say what a pleasure it is to be here and to see all of you in person instead of confined within little squares on a screen. And as Ben, first of all, you can all hear me, yeah? Okay, great. As Ben has said, what I am interested in, it aligns pretty closely, I hope, with what you're all interested in, which is why you're at a lecture series entitled something around social policy and innovation, which is that I'm interested in how, essentially I'm interested in the politics. It does squeak, doesn't it? I was warned there's a little spot there that squeaks, and it's true, actually, it's an entire panel. I'll stand here. I'm interested in the politics of how decision makers at various levels of policy processes, including at the legal level, right down to the program level within the health sector, how people in those decision-making spaces interpret empirical evidence or decide to use empirical evidence, the kind of evidence that is collected from the sorts of people that you're going to be surrounded by for the next year at least, i.e. researchers, people who are paid to collect and interpret evidence for a living. You know, those are the metrics of our profession. How much evidence can we collect and how many papers can we put out there? So I'm interested in how those decision makers in political spaces look at evidence around gender, at the intersection between gender and health, and decide where to allocate their resources and what kind of health policy decisions they make on the basis of evidence around gender. So as Ben has said, I wear two hats, and one of those hats is very much an academic hat, which is as a professor at UCL. I'm not going to spend a lot of time talking to you about UCL this afternoon. I assume you can ask me anything about UCL if you're not aware of UCL. If I give this lecture outside of the UK, most people think I come from UCLA, which I think just indicates that the American university system has a much better marketing department, certainly than UCL does. But I'm actually going to talk to you about the other hat I wear, which is still an academic hat, but it's as co-director of Global Health 50/50. So let me just, So Global Health 50/50, we set this up 5 years ago, 6 years ago, essentially on the basis of having been academics in the gender and health space for about 20 years and spent a lifetime really, what felt like a lifetime up to that point, collecting a ton of evidence around the role that gender plays in health inequities, and then constantly being surprised by how much that evidence was ignored. And really starting to ask ourselves, why is it that people are not paying attention to all of this evidence? And we can talk later about the kind of evidence that we felt was being ignored. But just to say that what it did was it spurred us, and I can come to the us in a minute, it spurred us to think there must be a different way of communicating this evidence. There must be a different way of trying to get our message across. So the us, in full transparency, is me and my husband. There, no, there's nothing more gender equal than a husband and wife team, or a married team, or a couple of any kind of partnership whatsoever, trying to push forward together on issues of gender equality. Because believe you me, if I was giving this lecture in most of the global health space, and it had gender in the title, I can guarantee you that 95% of the audience would be female. So we're always very grateful that men are also willing to walk into a room entitled "Let's Talk About Gender Equality," because it doesn't happen that often in the global health space. My husband's a political economist of global health, and so he, for 12 years, was head of political strategy for a UN agency working in health. And with his training in political economy and mine in the sociology of decision-making, we set up Global Health 50/50. And one of the great things that you learn in the UN is to be incredibly alliterative. So you'll see across all of our communications and outputs, people working in the UN are really great, giving you sort of motivational, alliterative commands. So we aim to inform, inspire, and incite. What turns out we're actually not the only ones with great alliterative skills, because the way that what we essentially base the model of our action on is a theory of policy change that you may already have been exposed to in your studies so far, or you may be exposed to in the coming year, or you might only be exposed to it in this lecture. But I would strongly encourage you to look at it, because I think it's actually a really, really useful way of trying to understand why policies do or don't change. So this is a theory from an academic called Peter John, who I think is now at King's College London, who essentially based most of his work on trying to understand or trying to explain decision-making, as far as I remember, within European governance systems. What Peter came up with, and on the basis of other people's work before him, was that, again, he's got the eyes there. It's the ongoing interaction of ideas, interests, and institutions. Okay, so Peter said, unless you understand what's going on in those three domains, it's really hard to figure out how and why policy changes. And if you want change to happen, you really have to ensure that there's action going on and that you've understood those three separate domains. So interests, and we're going to come back to interest groups later on. The people who stand to, what do people stand to gain or lose from your policy, right? Who's actually going to benefit from it? Who might conversely oppose it? Institutions. By institutions, it means the rules of the game, the norms of society, the way systems and structures are set up. It doesn't mean organizations like a university or the co-op. It means the actual systems and structures of society, and understanding the rules and the values of every society that you're operating in. And then here's where the academic side comes in, ideas. Empirical evidence, it falls within the domain of ideas. It's part of just a set of notions about how the world operates. And again, we can come back to lots of discussions about how ideas and evidence around gender and health are framed, and the epistemology of whose voice counts within the academic domain of putting those ideas forward. But Peter's framework, which really sits at the core of everything we do as Global Health 50/50, is to make sure you understand and act on those three interlinked domains. And for those of you who are really into strategy development, this is our theory of change. I won't bore you with in too much detail. But you'll see that ideas, institutions, and interests really act right at the center of what it is that we're trying to address, okay? And a large part of what we're trying to do, and this is where I think, I would say in terms of looking at the average age of, or the mean or the median age of everybody in the room, when I was at the stage of my career that you're currently at, I don't think I understood this part nearly as well as I've come to understand certainly over the past 10 years, which is that the question of framing is really, really important in terms of how we try to change things, how we try to make the world a better place or get a policy into place where none exists, or change an existing policy. That a very large part of what we're trying to do is argue with people with a different set of frames, with a different set of ways that they see the world. And what that then boils down to, and for us has been absolutely central as a working model for how we work in Global Health 50/50, is that essentially when we set GH 50/50 up, for the first 4 years, the largest part of our expenditure went on communications. It went on people who could actually communicate academic ideas and empirical evidence in a way that everybody else could understand it. Because one of the things that really characterizes academia otherwise is we're all really good at talking to ourselves. And if we try to talk to other people, they haven't got a clue what we're talking about. And I say that, as somebody who spends a lot of time, for example, talking to the media, and we can, again, come back to some of that in a moment, but how we frame our ideas, how we talk about the evidence that we're trying to push into that public policy decision-making space is really, for all of us, has been an incredibly important lesson about the use of our own resources and the use of how we get messages across. So what is it that we actually do? Well, here are the kinds of outputs, and I'm going to dive more deeply into one particular set of outputs in a moment. One of the things I think you'll agree, hopefully, by the end of this talk is that we're really good at collecting photographs. So every year we run an annual photography competition because we were really, really fed up with the notion that when you talk about gender in global health, that what most people seem to hear in their brains is the poor, vulnerable woman who needs saving. And we wanted a much more positive image of what gender means to people. And so every year we hold an open global photography competition, and you'll see you'll see a range of the photos as I go through the talk. And it's a way of putting out really different messages about what gender means to people's health outcomes, because one of the things that was really, really clear to us from all of the academic work that we had been doing for so many years is that not only does gender mean vulnerability in the global health space, but particularly gender means women. And gender particularly means women's reproductive capacity in the global health space. And so we wanted to step out of that space and say, well, what does it mean to everybody else? Now, I know that lots of you want to have a very intense debate about what it means to you, and I'm very happy to do that. But I just want to just sort of put it out there that what we're trying to do as Global Health 50/50 is understand the huge spectrum of ideas and frames that people operate with when they think about gender and health, that there's no one right answer to the notion of gender and health. So every year we analyse the gender equality status of 200 organisations in the global health space. So every year we look at organisations in the UN space, in the bilateral space, the private sector, the public-private partnerships, the faith-based organisations that are an incredibly important part of health systems, particularly in sub-Saharan Africa. We look at the big NGOs, you know, the Oxfam, Save the Children, etc. of the world. We have 10 sectors that we look at, totaling 200 organisations, and we assess them and we say, okay, what are you doing to promote gender equality and a more diverse workforce within your own organisation? What systems and structures do you have in place to actually promote equality of opportunity for your workforce? Okay, so that's one domain of what we look at. And then the other domain is what systems, what do you have in terms of equality of opportunity for who benefits from your work? How does Oxfam decide who gets to benefit from Oxfam's work? How does Pfizer decide who gets to benefit from all of the amazing R&D and billions of dollars that Big Pharma spends? How does the ILO or the FAO, the Food and Agriculture Organization, how do they visualize gender and therefore who benefits from all of the incredible work that all of these organizations do on gender? So every year we compile all of that into a massive searchable online database. Okay, so anybody can just go to that database and look at 5 years of data from those 200 organizations. And we put it out with a lot of aplomb into a big report that's available on our website. And yeah, here's kind of a bit more detail about the index itself. And we also provide links to where we find a policy. You know, one of the things we look at, you can't have equality of career opportunity if people don't feel safe in the workplace. So what does your sexual harassment policy look like? And do you have training? Do you have mandatory training? Everybody who works for your organisation on that sexual harassment policy. And then we put links to those online policies on our index. And just to explain, we then put it out in this traffic light system, which we think yet to discover a country where traffic light systems are not understood. Most countries do seem to understand the notion that red essentially means you're not doing as well as you should, amber means you're kind of okay, and green means well done, you're doing okay. So we put it out in this color-coded index, and a large part of what we're looking for is, because we are an accountability mechanism, a large part of what we're looking for is transparency. Can we actually find your policies? Can we actually find your data? The second principle that we operate with is independent monitoring. You can't write and tell us that you don't want us to monitor you, because that's not an independent monitoring system. So we base our notion of accountability on a framework that was developed by the UN Special Rapporteur on the Right to Health. So 3 principles of accountability: transparency, independent monitoring, and the notion of remedial action. But we don't have power for remedial action, so we rely on the rest of the system to exert that. Okay, so I'm going to present to you now a lot of data on our second domain, that domain about what role gender plays in health outcomes. In case you're all wondering, when I finally get to start talking about COVID, here it comes. But before I start, let me tell you the definition of gender that we operate with as in our monitoring, okay, we could spend not only the rest of the hour available to us, but I'm sure the rest of your course thinking about what gender means. And I say that because we've spent 2.5 years as the Lancet Commission trying to figure out what is it we mean by gender, okay? What are we all talking about? In the world of global health, we have one agency at a global level that exists in order to set norms and standards, and that's the World Health Organization. So since we have this global organization that sets norms, we decided to use their definition of gender in order to monitor what other organizations are doing, okay? Because we can say, we don't like this definition. We've got lots of feelings about this definition, but this is the minimum standard that all organizations are supposed to be operating with. So this is how WHO defines gender, and we can pick this apart endlessly, and we will, I'm sure. But just to say, this is what we use for monitoring, okay? And we put that out there because we're aware that lots of organizations either equate gender to just mean women and girls, or they equate gender to mean biological makeup in the health realm, okay? And if you look at analyses of published papers from the health establishment, the kind of work that's done in universities like this one or my one, 85% of people working in health who publish papers use the terms sex and gender interchangeably, okay? So we need some kind of standard assessment that we can monitor organizations by. But just to say, in the Lancet Commission, we're much more complicated than that. And so in the Lancet Commission, we see gender as something that is driven by, that's essentially about the distribution of power in society, okay? Gender is a representation of who holds power, what drives the distribution of power. It exists in those institutional structures that I was talking about, the rules of the game is determined by history, by politics, by social norms, etc., etc. So we fully understand that gender is a lot more complicated than we're measuring it by. But at the end of the day, we're dealing with, in our assessments, certainly for COVID, what we were dealing with was data being put out by ministries of health. And I can assure you, before we start, that people sitting in ministries of health, generally not gender experts, and that's the story I'm about to tell you. So when COVID started, we were all aware that there was going to be a difference in how COVID was experienced, because we had all been brought up to understand the notion of the social determinants of health and why people do not have equal health opportunities in their lifetime, okay? So we knew that COVID was very unlikely to be different to any other disease or illness you can think of, which is that it is associated with inequalities across society. Most of those inequalities run in a fairly predictable gradient. All get sicker, people in rural areas tend to be sicker, etc., etc. And we knew that in the case of COVID, that previous coronavirus pandemics had shown male excess mortality. So when the pandemic started off, we wanted to look at that data, and then we simply couldn't find the data. We went to that World Data Mapper Tracker, whatever it's called, I've forgotten now. They weren't presenting the data in a sex-segregated way. We went to WHO, they weren't presenting the data in a sex-segregated way. We looked at a few governments, and very few of them were presenting the data in a sex-segregated way. And we thought, well, this is crazy, because actually this is a big inequality in society. We need to see what's going on. So foolishly, we decided, okay, we'll do it. So for 2 years, we have tracked data being put out by national governments. We don't track papers and one-off surveys or cross-sectional reviews of populations or whatever. We only track data from national governments. And what we're looking for, and we've been looking for it for the first year, we were looking for this every single week. We now do it once a month. But what we're looking for is, okay, what are you telling us as a government about what you know about COVID in your population? Really, with the understanding that governments have been urged since the mid-1970s to present disaggregated data, okay? Because we can all sign up to the notion at global level, for example, of leaving no one behind. But unless you disaggregate your data, which seems a bit technical and niche, but unless you do disaggregate your data, you won't know if you're leaving anyone behind. You won't know who's not getting covered with services. Alternatively, you won't know who's actually at risk of a global pandemic, for example, unless you have minimal attempts to disaggregate your data. And sex disaggregation, male, female disaggregation, should be possible by every single health service in the world, because I bet no matter where you're from in the world, when you go into any kind of healthcare setting, somebody somewhere is ticking a box to say whether you identify as male or female, or possibly non-binary or other, depending on where you are in the world. But it's impossible to imagine a health system that doesn't have this data there. Okay, so our question was, so what are they presenting in terms of COVID data? And the answer was that over the course of the 2 years, the top line tells you how many countries actually presented sex disaggregated data. And then the bottom line is how many have presented it in the past 2 months. And I think even if you're not epidemiologists, I think you can see when you look at a slide like this, that this tells you that people are making discretionary decisions about whether to present disaggregated data. Because if it was put into the system, if this was a system change, if this was some clever programmer writing code, those 2 lines would have the same numbers on them because it would be an automatic generation of the data. But it's not. People are sitting and making decisions. Oh, it's not important this month. I don't need to present the data. And that was what we found. We found exactly that countries, including this country, that presented data disaggregated 1 month wouldn't do it the next month, with no real rationale and rhyme or reason. But overall, here's what we found. What we found was that for every 10 females who get tested, there are 8 males who get tested. This is global data, right? So we're going to come back to that in a minute. For every 10 females who get diagnosed as a case, there are 10 male cases, which is what you'd expect. But more men get admitted to hospital, and a lot more males get admitted to ICU. So they get sicker, they get much sicker, and then they're about 30% more likely to die globally. And that varied from country to country. In some countries, that was about 300% more likely to die. And in some countries, it was about equal, okay? But the global average was that there are these differences, okay? So these are significant differences. Again, even if you're not an epidemiologist, a 30% higher chance of death is a pretty significant difference in a pandemic that has affected so many millions of people. What we also found was that globally, several months into the vaccination program, we had about a 1-to-1 vaccination rate. But I'm going to focus a little bit more on the vaccine data for you. And what you'll see in this slide, you don't need to worry about the names of the countries, although I can talk you through it if you want. So the purple lines are females, and the blue lines are males. And you see, okay, we saw globally a 1-to-1 ratio, but if we look at country level data, we see big disparities in terms of who gets access to vaccines. Now, some of this is actually pretty easy to explain, does that? Yes. A country like okay, what's in my hand? Okay, I'll point. in an old-fashioned way, I'll just point. A country like Qatar, the reason you see lots more males getting vaccinated compared to females is because actually the population of Qatar is about 80% male. So it's kind of, you know, you can explain some of this, but a lot of it is not very easily explainable, kind of at first glance. But what we do have is a whole history of studying why we see differences in things like vaccine uptake between males and females. COVID is not the first pandemic, or not the first epidemic come along that needs a vaccine, and where we see differences in how males and females respond to the vaccine. Indeed, it's not the first health condition where we see differences in how people respond to the opportunity to have health, the illness preventing interventions. We see differences between males and females. What we know, and these are really big picture statements I'm about to make, what we know is that globally, women use health services more than men do. And the reason for that is kind of really, really obvious. It's about their reproductive health needs, sex and reproductive health needs. Women need contraception, women have babies, women take their children to get vaccinated or to have a checkup or to sort out the child's glue ear or whatever. So women use health services more than men do. We also know that women are much more likely to use what are called primary prevention services. Primary prevention means having something done to you to stop you getting sick or infected in the first place. A vaccination is a perfect example of a primary prevention. Women are much more likely to get vaccinated. They're also much more likely to go for screening. If you've got a population of, let's say, 100 people, 100 males and 100 females, and you offer screening for hypertension, high blood pressure, or you offer screening for diabetes, you will find it's women who come and get screened more than men do. And it's, you know, there's a tendency to put all of that down to, oh, you know, the bad behavior of men. It's all about individual men's choices, and to kind of totally ignore the entire social determinants of health framework. And once you start thinking about those differences in terms of social determinants of health, and actually a lot of the reasons why men don't seek services actually lies within the setup of the health system itself, okay? Some of it might indeed be down to the choices that individuals make, but a large part of it is the way we set up health services and make them accessible to women, particularly women, quote unquote, of reproductive age. And we don't make, this is outside the UK. The UK is an anomaly, it's an outlier. We have free at the point of delivery healthcare services, not working particularly brilliantly right now. But in general, anybody can access healthcare when they need it. That's not the case for most of the world, okay? So how we set up health systems and who we decide those health systems should serve very frequently is a very big driver of who uses those health systems. The US is a really great case in point. Yes. Point in case. So you've got a system that is definitely not free at the point of delivery, where there are massive social inequalities in terms of who gets access to services. And you have vast levels of mistrust in the US health system and decision-making system. And so a survey of 50,000 adults in the US, a general population survey, essentially found that 10% of women and 8% of men will not get vaccinated. 13% of women, 10% of men unlikely to get vaccinated. And we've seen those figures played out across the US, and we know it's determined by who you vote for and where you live and et cetera, et cetera. But we also see that there are big differences in why people tell you they're not going to get vaccinated. And a large part of females' concerns about vaccines, why they won't get vaccinated, relates to a mistrust around reproductive safety, okay? Part of which boiled down to the vaccine trials excluded pregnant women. Now, if you're a pregnant woman, or you plan on becoming pregnant fairly soon, and somebody offers you a vaccine, which is where the trials have specifically excluded people just like you might be somewhat more hesitant about, is this vaccine really for me? So we know that gender and social norms around gender have played a big part in vaccine uptake, which can begin to explain some of those big country level differences that I showed you. So how did policymakers respond to that? Well, one of the other things we did at GH 5050 was look at vaccine policies around, I think, 76 countries. We were able to find vaccine policies in, I think this is 37 countries. And we looked at those vaccine policies for the 37 countries, and we said, okay, how much given all of that, given everything that years of research evidence have told us about what role gender is playing in the willingness to be vaccinated, and everything we're seeing in terms of women in many countries saying, I don't want this vaccine because you haven't shown me that it's safe for me. What's the policy response to all of that? How many of these policies actually take sex and gender into account at all? And what we found in the 37 countries where we could find the policies on vaccines was that 92% of the countries didn't mention sex and gender at all. Okay, so sex and gender is completely absent, despite everything I showed you in all of that empirical evidence, all of that data, all of that published evidence from similar situations of vaccine uptake, etc. When it comes to actually making a decision, putting words on paper, sex and gender aren't there. So then we thought, okay, why aren't sex and gender there? Now you need to tell us why it's missing. So then we interviewed COVID vaccine policy experts at global level and a few at national level, and said, why did you ignore all this data? We spent weeks, months, years collecting all that data. Killed us. We never had a weekend for 18 months. You've ignored us. We put all of that data in easy to use formats, and you never used it. What's going on? And they said, well, this is what's going on. So what we discovered was that the reason that there's a gap between evidence and policy when it came to sex and gender in COVID vaccines was that, first of all, in most countries, there is no regulatory need, or there's no institutionalized need for regulatory mechanisms to disaggregate their data. So when you're presenting data on vaccine safety, there's actually no regulatory requirement for that to be sex disaggregated. And so policymakers then never thought about it because nobody was presenting them with sex disaggregated data on the vaccine. So it was just absent from the people making the vaccines, and the people testing the vaccines weren't thinking about sex and gender. The next was that what we heard was equity. I mean, it wasn't just around gender, but equity, that wasn't a priority. We've got a pandemic on. We're really, really busy. We've got other priorities. Got to get the vaccine out the door. We haven't got time to think about equity issues. That's just a bit of a, fluffy add-on. We'll come back to that later. And then basically, the people making those policy decisions were really, really great technical experts and didn't understand sex and gender or other aspects of equity. And part of that boiled down to that gender and health exist in separate silos in most ministries, in most universities, in most policy-making spaces. These are two separate communities who very rarely come together because all of the gender experts are over there in the women's ministry. Or if you're lucky, they might be dealing with some childhood illness stuff. They're not dealing with all of the big important stuff that the health ministry is dealing with. And you can see that from data collected from UNDP, which is, if you look, they looked at the gender breakdown of COVID vaccine task forces and essentially found that women were missing, which very much fits with the data that we collect as GH5050, where every year amongst those 200 organisations, we look at who leads the organisation, who's the CEO and who's the board chair. And what we find is that 70%, this data has barely changed in 5 years, 70% are male, 84% are nationals of high-income countries, 94% are educated in places like this, not educated in places over there. And only 5% of global health leaders are women from low and middle income countries. This year, when we looked at boards of these organisations, we looked at 2,000 board members, and boards are where decisions are really made. The CEO is the nominal head, but the board is where the board holds the power, right? Amongst 2,000 members of boards, 15 were women from low-income countries, 15, whereas 45% were American. And this kind of summed it up. The only time you see a woman is when she's the vaccinator. In other words, she is generally the unpaid healthcare provider, the voluntary community health worker, doesn't get paid, but is responsible for delivering these amazing health interventions invented in places like this and elsewhere that rely on the unpaid labour of women to deliver them. But those women don't get to sit in the boardroom. And hence we would argue, as GH5050, bringing those two domains together, when you don't have equality of opportunity in terms of who gets to make decisions, you don't have equality of opportunity in terms of who benefits from the decisions the system makes or the decisions the organisation makes. So final two slides. The summary here is, I would say, gender's not an add-on. Gender and other indicators of inequality and inequity are central to decision-making processes, not some kind of fluffy add-on that you think about at the end and tick a box saying, yeah, I've mainstream gender here, needs to be considered right from the start. And I say that, I put this slide in, as Ben was watching me put this slide in right now, so because this is an email that came into my inbox this week. And it's a plea to all of you as when you leave here. Now, I know that's a terrible thing to think about in your first week, because you've got an entire year of enjoyment ahead of you. But when you do leave here and move into the decision-making spaces that you will occupy, I really want you to think about this slide when you think about gender, which is that we might all be on the same page and have signed up to the notion and the commitments and the goals and the principles of gender equality. What you see on this slide is a set of terms that last week was the meeting of the UN Food Security Council. So the UN Food Security Council sounds, they've got their work cut out for us, for them right now, obviously with challenges to food security and for all sorts of reasons. And they were having a discussion around a document on gender and food security. Now, anybody who stops and thinks about who actually farms the food is insecure and who is responsible for production lines and who actually is responsible for shopping and cooking and et cetera, you don't need to be a gender specialist to know that gender is absolutely front and center of food security, let alone food insecurity. What these terms are phrases that a very large number of governments sitting in the UN Food Security Council objected to because of their inclusion in the Food Security Council document. And when one country objects, the entire document gets sidelined. So we're talking about countries like India and China and Indonesia and Russia and a whole host of other countries that will not allow mention of gender in UN documents anymore. This is not the first time it's happened. It happened back in May this year at the World Health Assembly, where the entire HIV strategy, it ended up in a situation where 120 countries walked out of the room rather than vote on the HIV strategy because it included two terms. One was comprehensive sexuality education, and the other was gender identity. So this is not just about sort of fluffy add-ons. This is actually about the politics of who we are as societies, and particularly as global societies negotiating equality for all of us. Thank you.